I appreciate it. This is a topic that is near and dear to my heart just because I think it serves to provide a future treatment option. So I will share my screen and we'll get started here in a second. It's one of those things where the principles are certainly there, and the scientific evidence may be overlapping between MSK and spine conditions. So that's why I kind of brought the topic together in terms of treatments for spine and MSK. The basic science principles and some of the other principles are very much overlapping and similar. And to that, I would consider spine pain mimickers as MSK conditions, shoulder pain, hip pain, things that really overlap, neck and shoulder syndrome, hip spine syndrome, and the like. Disclosure is not relevant to this talk, except for the fact that I do have a few grant applications currently submitted pending to study PRP for intradiscal pathologies and intradiscal treatments and regenerative options as far as targeting the disc from a more than a palliative, but from a reconstructive standpoint is focused on my clinical research. The outline, what I'm going to be going through today is regarding some regulatory affairs, basic science overview, further discussing PRP and stem cells, as well as overall treatment overlying principles. Low back pain, leading cause of disability worldwide. I don't think that's news for anybody on this joining us today. And it should be the priority for future research, prevention, for therapy, not only for palliative measures in terms of pain management, but also reconstructive and definitive treatment to help alleviate the burden that low back pain has on the world, not only health policy, but financially as well. So there are limited treatments for discogenic back pain, and that's going to really be the focus of the regenerative treatment options, as we do have pretty good treatment options for other sources of lower back and disability. Intradiscal injections of biologic agents such as PRP or stem cells are theorized to have regenerative properties and have been gaining increased interest as possible treatment options for a multitude of reasons. There are numerous other compounds that have been studied, everything from fibrin gels, autologous nucleus pulposus, and disc cells, amniotic cells, and concentrates. The evidence, however, is lacking and not extraordinarily well defined. So before we start getting into what are the treatments, what is the goal and what are we really trying to accomplish? Can we speed up the process? Can we treat the process? Can we allow for tissue to heal? The goal of regenerative medicine is to facilitate healing, but how do we actually accomplish that in vivo with exogenous compounds, be it autologous or allogenic? Can we slow the degenerative cascade at all? Can we stop it? What are we trying to do? Are we trying to reduce pain? Are we trying to treat? Are we trying to fix? That has to be at the premiere of what we're going to be trying to focus on. So what does the FDA say we can do? Well, we're allowed autologous stem cells taken from your own, adding blood products, PRP, fibrin glues, which is platelet-poor plasma, centrifugation, and marrow cell contained in bone. What are we not allowed to do? And this is what I'd like you to pay attention to, because a lot of people do this. So be very, very weary of treatments and clinics out there. They're saying, well, we're going to take your cells, we're going to sort them, we're going to purify them, we're going to add growth factors, we're going to enzymatically cleave them in order to provide the utmost treatment success. Well, that's not allowed according to the FDA. Why? Because then you're creating a drug. Now, that's a different ethical and theoretical issue, which we're not going to get into. But overall, the overreaching statement by the FDA is that regenerative medicine therapies have not been approved for the treatment of any orthopedic condition, such as OA, tendinopathies, disc disease, tennis elbow, back pain, hip pain, knee pain, or shoulder pain. Now, we are using it as a off-label. We are using it as a trial and clinical trial basis, but they have not been approved or evaluated by the FDA, which is actually true for quite a few treatments. And this slide applies to clinical practice and not IRB approved clinical trials, where we do look at cultured and mixing of cells, sorting of cells, and other processing in order to optimize the delivery of what we are trying to deliver to an injured tissue in order to stimulate the healing process. So in order not to be considered a regulated drug, both blood and bone marrow must be autologous and no more than minimal manipulation. Manipulation usually is centrifugation and cannot be combined with any other product. This is according to the FDA regulation as stated below. I'm going to mention stromal vascular fraction just because I'm going to mention it in future slides. So for those that are unaware, it's essentially not a naturally occurring substance. It's a stress process to generate new cells with novel properties, whether they be good or bad, from a fat sample. It's not well understood, but stromal vascular fraction could be made from almost any tissue to isolate stromal cells, and that's just another name for, you can think of it of another name for mesenchymal stem cells. The basic idea is that a wide variety of cells within fat tissue are separated from the actual globby fat, and then these cells are concentrated to make stromal fractionated vascular fraction, essentially. So what are we allowed to do in the office? Well, PRP and bone marrow concentrates are permitted as long as it's autologous, meaning same day, same office, same patient, hospital, nothing is added, nothing is removed, and centrifugation is the only manipulation. Most PRP products, you just take the blood, spin it down, 1 spin versus 2 spin, depends on the formulation or the product, centrifuge or the company you're using. We may not access stem cells from adipose into stromal SVF, and this is beyond minimal manipulation. And amniotic products are commercially available, however, the regulation is unclear, but the evidence shows us that there really is no stem cells in amniotic fluid in the commercial preparations. So let's have a brief overview before we get into each exact regenerative treatment option. A stem cell can be derived from bone marrow, fat, or peripheral blood. Bone marrow is taken as a whole aspirated and concentrated via centrifugation. Now, bone marrow access is actually quite painful. It's taken from the PSIS of the posterior hip, the posterior superior iliac spine. It's done with a needle that essentially carves out a piece of bone and that gets fractionated. So stem cell treatments, at least autologous stem cell treatments, are very painful because you have to get them from some bone. So you have to stick something into the bone to get stem cells out, which is not painful. There's some evidence of PRP working with annular tears. I'll go through that a little bit later. There's some evidence for use of PRP in knee and hip and ankle OA and other soft tissue disorders. Amniotic tissues, like I said, supposedly have similar growth factors and have been used in wound care. However, the growth factors may be dead and there's really no studies, and it's technically, if you look at the FDA guidelines, really not allowed. So what is platelet-rich plasma? Platelet-rich plasma is a concentration from whole blood containing growth factors, cytokines, and such. And you really want a high concentration of platelets. Now, normal platelet counts is somewhere in the 200,000 to 300,000 range. If you're able to concentrate that at least 3 to 4 times, some of the studies have shown that the magic number seems to be 1 million platelet parts. And that is going to be difficult to get with some preparations. There are some companies out there that may concentrate 2 to 3 times. If the concentration of the whole blood is about 220, 230, 250 even, then you're still talking about 750,000 and not necessarily a high enough concentration of platelets to actually do what you want it to do. And growth factors are concentrated with the PRP with, there's some evidence of increased collagen content. And like I said, most available commercial kits concentrate at least 5 to 6 times, and that's what you really want to be, as having optimal outcomes, and any preparation yields should not be inadequate. Now, how does PRP actually work? Well, the proposed mechanism as a therapeutic agent is to stimulate the body's own repair process, modulating inflammation, delivering growth factors to the injured tissues, essentially activating stem cells which promote a healing environment. So if you're able to concentrate platelets, in layman's terms, deliver to an injured tissue, those platelets are going to signal your body to heal whatever platelets are being attracted to, almost like a scab, for example, treating the underlying cut when there's platelet aggregation to form that clot. In vitro studies have shown PRP to induce downregulation of inflammatory molecules, which can attenuate hyperalgesia. Does pain relief come on its own? Does it constitute an indication to promote the use of PRP? Is there functional improvement seen with these patients due to the analgesic effect or the tissue healing response? just some questions to think about as we continue our adoption of PRP into clinical practice. There's an antibiotic mechanism to PRP as well. So is it treating a subclinical infection? As a study from China showed that there may be a subclinical infection that creates disc degeneration. So a lot of different mechanisms that we are not yet 100% sure how things do get better. So the clot creates a healing cascade. Those alpha granules will create proliferation, differentiation of the extracellular matrix and other cognitive connective tissues with pro-inflammatory and anti-inflammatory effects. And that's why when you do PRP for soft tissues such as tendons, you have this spike in pain initially for the first couple of weeks before things tend to calm down. So you have to warn patients when you do this that you're going to have a flare of pain before things calm down, sort of consistent with the tissue healing time frame of about 8 to 14 days until you actually get good clot or scar formation, which is when PRP begins to work. So what is the evidence for PRP? Well, it's mild to moderate knee osteoarthritis. Tendinopathy has some good evidence, especially for gluteus medius, greater trochanteric pain syndrome, a little bit less for patellar tendon, rotator cuff, and the adductors. But the spine, definitely the discs, less so or much less so for joints, epidural use, and soft tissue disease. So in the animal studies, we have really good evidence for PRP in rabbit and disc model, and this was shown, as you can see on the picture on the left, with preservation of disc signal, increased expression of mRNA, with pretty good outcomes, at least in the in vitro world in rabbit discs. When you look at the literature review, it's consistent and well-defined in vitro results. However, again, the in vivo studies are more variable, but still positive. It's also just pain relief or healing. So that's one of the things that we really have to decide. Are you putting in a substrate that's going to relieve pain, but are you actually healing? Or does the initiation of the substrate leads to healing or pain relief? And you have to really decide what the goal here is, or do we care if people get better? Does it really matter why? Clinical reports do suggest that intradiscal injection of various PRP presentations into degenerative disc does have positive effects. There are not many, but there are some clinical trials, and these are just the only 3 that I'm familiar with that are randomized and controlled with a success rate that's somewhere between 50 and 60% overall. Levi showed that platelet-rich plasma injection into discogenic disc disease does help for about 50% at 6 months. Again, intradiscal autologous plate PRP to treat discogenic back pain, a clinical trial in 2017 shows efficacy of up to 6 months. Other clinical trials or reviews of clinical trials, especially with the ACIP guidelines here, the top portion of it shows that there's a level 3 evidence for the intradiscal injection. Now, it's not level 1, it's not level 2, but there is some suggestions that it does seem to work. And a critical review did find that PRP was safe and effective in reducing back pain. There is great application of PRP or potential for PRP, and it does have a consistent analgesic effect. Is this effect greater than other therapies? And we really have to find out if that's true or not. But it's kind of a rhetorical question because there's really not a good treatment for discogenic low back pain. Just another picture of a study that I referenced earlier, which is the intradiscal injection of autologous PRP. And you can see that there is sustained improvement even up to 4 years. And this was a follow-up to an earlier study. Again, treatment satisfaction is relatively high, but the overall numbers of patients treated still remains low. And I think that's why we really need more evidence to show that PRP is going to be effective, especially for treating intradiscal injuries, and why it's such a personal interest of mine, because if we can treat the disc, I think that's the last holy grail when you're talking about spine care. A couple other studies that PRP does show sustained benefit versus corticosteroids for intra-articular injections with local anesthetic. Steroid versus PRP show that PRP is better to treat SI joint pain at 6 weeks and at 3 months. And we know that PRP is kind of hit or miss for SI joint injections anyway. So, summarize the PRP intradiscal research. It's preclinical data, in vitro and animal studies are excellent. Results of clinical trials are modest but encouraging. Potential treatment options for discogenic pain in the right pain is an option. I have done several, and most of people get better somewhere in line with what we see in the literature of about 70%. So, 4 out of 5 people will get better, a little bit better than that. So that's why it's such a focus of mine. If we could get a clinical trial for PRP, or at least a pilot or feasibility, then it could open up this treatment, which is not covered by insurance, to more people. And that's why I'm trying to get some funding. So again, I firmly believe that PRP or some version of a blood product will be developed to heal injured tissues. In the right patient at the right time, the right treatment may just be intradiscal PRP. Moving on to stem cells, can be derived from bone marrow, adipose tissue, or an allogenic amniotic placental tissue fluids, but the latter being not living cells. Bone marrow is taken from the hip, usually PSIS, with a Jamshida needle, and it is quite painful. So it's not a non-painful procedure, and you have to get those stem cells from somewhere. And you can see on the slide here, this is what it looks like right up in here. So fat aspirate, derives from liposuction. You can separate cells mechanically, ultrasonographically, enzymatic digestion, and potentially higher yields, but that's still yet to be determined. Mesenchymal stem cells are signal cells. They're pluripotent, multipotent, they're endogenous, and they're able to differentiate into a multitude of musculoskeletal tissues, including bone and cartilage. So mesenchymal stem cells, this graph shows the number of clinical trials registered per year starting in 2000 for mesenchymal stem cell-based therapy, and this data is from clinicaltrials.gov. So every year, an exponential increase in the number of studies. So this is good news. You know, we do need more evidence to show that it works, or if it doesn't, figuring out what actually does and how we can use stem cells to our advantage in terms of treating musculoskeletal and spine pain. Some research suggests benefit is not directly from regeneration, maybe reconstitution of tissues. So it's still yet to be determined. Prospective clinical trial looking at percutaneous injection of autologous bone marrow concentrate, VASD reduction 79 to 33 at 1 year. So again, promising results from some prospective outcome studies. 2 additional publications looking at 2-3 year data is promising as well. There's cultural cell trials that have been ongoing for several years now, looking at allogenic, intradiscal, adipose-derived, different types of formulations in order to optimize pain relief to the best possible advantage giving to us. So stem cells, think of cultured as activated. The gap in the science at this time is how do we have influence over the stem cell to produce or generate the appropriate self-tissue growth? We can harvest, implant. However, we are unable to ensure that the injected BMAC, which is bone marrow, actually performs the desired action. This is the last frontier of regenerative therapeutics and techniques. If we can figure out how to confirm or certify or ensure that the injected stem cells perform the action that we want, I think that's going to be where the science takes us into something that's really useful clinically. So discogenic, intradectable cellular and biologic products remain investigational. Cellular therapy offers significant promise, but clinical evidence is lacking and there remain significant hurdles to overcome. I believe our best chance for making a disease-modifying treatment will be an autogenic material with appropriate patient selection and some processing of that material to yield an optimal drug action. It would be tailored treatment, and it's the right treatment at the right time for the right patient. I think you've heard me say that a few times already. Now, I finished fellowship in 2013 with significant hope that by this time, within 10 years, we would have an injectable cellular treatment, but that's really not so. The treatment of degenerative disc disease with regenerative therapies remains elusive. I do think that PRP or some version of it is the future, but we're not there yet. So just be really weary of what's being sold to you. It may just be a bill of goods. So, hey, doc, is this going to help me? I don't know. We do have lab and animal evidence that it could help. We've just a few studies in people which shows benefit, but again, I don't know. I think there's great potential as evident by my clinical research, by some of the studies that have been recently done over the last few years. I performed several intradiscal PRP injections with relatively good outcomes in very select motivated individuals. As with most treatments, selecting the appropriate treatment for the right patient at the right time is important. And just as important as the procedure choice is the appropriate post-operative rehabilitation, post-procedure protocols that optimize recovery and return the patient to their functional ability. So be ethical, consider research, and educate your patients that this is not a panacea. It's not going to help everybody. And where we're looking at is a very narrow view of what is possible. But sometimes you just have to take a step back, look at the whole picture before we make a decision as far as what we're trying to achieve in helping patients with low back pain. So